What is up, y'all? Tyler and I back for a riff, and I had posed him two topics of discussion. And the second one, I was like, dude, we actually may not agree on this. And turns out we do agree a little more than I think. But I have been thinking about this topic very recently. And who better to rant with than Dr. Tyler Kallasy on it? I think I've been in the PT space as a physical therapist since 2014. I've been in the PT space since 2009 or 10, probably. Maybe even earlier than that, 2006, right, as a tech. And I think what we've seen as a pattern in the PT space is these massive pendulum swings. We've gone from everything matters to nothing matters. And the reality is we always land in the middle. We've gone from no evidence matters to all evidence matters, and we end up landing somewhere in the middle. And the interesting one that I think is happening now is this concept that training is rehab and rehab is training, and that they are one and the same. And I don't know that I agree with that because what I feel like is happening in the rehab space is we've gone from under progressing clients to now over progressing clients by basically making functionally painful people and saying that that's okay. Now, the nuance here is I do think sometimes that is okay. The question becomes, are we blowing past a window of opportunity that just actually needs to look like rehab to get somebody out of pain and into a full level of function? What are
Yeah,
your thoughts?
my thoughts are anytime our industry, right, we'll say the rehab or fitness industry, has our own internal riff about a concept, like you said, none of the evidence matters, all of the evidence matters, right? The the clients, the patients end up the victims here is
Yeah,
because
yeah.
they don't understand the nuance and the context. They can see the extremes and they're going to latch on to whatever one looks cooler or feels more aligned with them. And as providers, it's tough to resist the urge to do what clients think is valuable or what clients or patients want or what we think is going to keep people compliant and keep them around, right? To keep
Mhm.
our business alive. So I'm going to just, preface with that and say, like, yeah, we're all, battling with that all the time. Um, I do agree that I'm seeing a lot more of this whole almost like rehab doesn't matter, or we don't need to spend
Mm,
as much time in rehab as we think. We should get back to training. We need to load it. Like this whole load it thing is coming back with a different flavor.
just load it, bro.
Yeah, just load it. Just train it, bro.
Yeah.
Um, I do think there is good intent underneath it, but I think both providers and we'll say clients and patients themselves are like misinterpreting maybe how to get there.
Mm.
I myself am a big supporter of not waiting too long to be pain free.
Not
Now, I will
waiting too
say,
long to be pain free. Hmm.
yeah, I will say
Elaborate on that a little bit.
that is within the context of the fact that I work mostly with people who have been dealing with chronic pain,
Sure.
long standing pain, not traditional chronic pain, 12 weeks. I'm talking months,
Yeah.
years,
Years.
cycling in and out of
Hmm.
I'm good, I'm not good. I lean into that shtick, that trope of like, you don't need to wait until you're pain free because I believe it solves to some degree the problem of I feel good now. I'm going to go hard. And I don't feel good. I'm going to completely rest, right? The client, the
Right.
uninformed client or patient, only sees two options. I do think that providers and clinicians are starting to misinterpret you shouldn't wait, you don't have to wait until you're pain free by saying, well, rehab stuff is really minimally dosed in terms of intensity. This stuff is really high dose in terms of intensity, the training. So we might as well just do this. I don't think that's effective because we're basically teaching people that it's okay to maybe ignore, under appreciate their discomforts. I think the better way to talk about it is like we need to do this rehab stuff, right? The traditional things you're thinking
Yeah,
of,
yeah,
the
yeah.
clamshells,
Yeah.
the
Yeah,
bird
yeah.
dogs.
The tempo work,
And it's
the
okay,
different plane work.
right?
Yeah.
And it's okay to find that fire where we can while we can.
Yeah.
By the way, modifying stuff so that it doesn't hurt, so that you can train hard, is, in my opinion, a large percentage of the rehab. Just
Yeah.
not doing things that hurt, right? So I don't subscribe to like, well, back squats allowed the highest potential of load. Let's do it. I'm like, no, squats would be nice for you to do while we're doing the clamshells. Let's do a modified goblet squat to a box with a heel elevation so you can express a high level of intensity and just not make anything mad for right now.
Well, and here's the problem that I have with some of this, right? Is let's just because everybody hates clamshells, but I actually think that they have a place in somebody's program that's still doing higher level stuff. Because if you are weak in rotation, whether you're talking an external rotation clamshell or an internal rotation clamshell, whatever, however you want to picture it, I guarantee you that client can move heavy weight in a squat pattern, can move heavy weight in a hinge pattern. That doesn't mean that just because they can do those things, we don't need to train those other rotary patterns because what I've seen is globally everything gets stronger, but locally that weakness exists.
And that gap continues to grow.
And if that weakness is something that can contribute to the stability of the overall system, can honestly just maybe act as a desensitization, as a neural reactivation of the tissues, which is something that we know happens in the rehab process. Why are we so adverse to pulling those things out of a traditional rehab program rather than saying this thing solves this problem while this thing is going, right? And I'll use myself as an example here. I have been rehabbing this like elbow shoulder thing for it's honestly it's probably been like a year and a half at this point. And it's at the point where I don't have to think about what I do in training, but there's definitely days where I'm like this elbow needs a little TLC and this arm needs a little TLC, and it looks nothing like my training program would actually look. And the reason
Mhm.
for that is because the capacity of this thing is far less than the capacity of everything else. And so, what I see happening is we're seeing this trend of training capacity at the higher end tissues, and then the lower end tissues are not actually getting the stimulus that they need to adapt at a rate fast enough to catch up with everything, and we're shooting past this gap where we could actually resolve the painful area simply because we said, well, you can do all these other things. Well, there was a period of time where I could push jerk 225, but I had difficulty strict pressing 95.
Yeah.
So
Yeah.
are you
Yeah.
so are you telling me that I should just push jerk because I can push jerk? Like, no. There's a point where I need to break everything back to the foundation and rebuild. Now, the last point here is you brought up these clients with high level of chronicity, right? And I think one of the things that I don't even know if I've ever thought about it like this until we had this conversation. But one of the things that I think we need to audit is like, what do we actually feel like the success rate of this client becoming pain-free would be?
Yeah, how likely they are to
How
become pain free.
how likely, like if somebody has chronic low back pain for 10 years and it's cycled in and out, I think the likelihood of that person becoming pain-free is relatively low. I
Yeah,
think that's the person where we educate around what does training need to look like and what does decision making need to look like, right? Versus you have the person that had an acute bout of low back pain. They try to get back to everything. They're now 3 months in. They're kind of technically in that chronic pain window. But I think
yeah,
that person has a really high likelihood of becoming pain free so long as we don't just start training like an asshole because we think training is rehab and rehab is training. It's like there needs to be some specificity to the low back that we probably wouldn't do if we were just running through a global training program.
right, right. I think the one of the major issues, misunderstandings, is the problem that's trying to be solved. Right, when we have less chronic or more acute problems, and we are sliding too far into the training side of this rehab training spectrum, we're now trying to solve a rehab problem with training.
Yeah.
We've gone too far into the like, well, they can do it, so they should. This lower threshold tissue will join jump on the train with everything else if we just keep training it. On the chronic side, we are no longer necessarily solving a get rid of the pain problem primarily. Sure, we want to make it less frequent, less intense, less relevant in that person's decision making. But the main problem now becomes how can we do more with the problem? How can we make that problem stay the way it is or slightly less than it is for as long as possible while allowing you to have fun? In that scenario, I do think having more of a training heavy rehab mindset is productive. We get rid of nociception. We educate them on what's good and what's bad. We teach them how to be mentally and physically resilient. On the other side, which is where I think it's being misinterpreted, I think there's three main barriers or reasons why we're seeing practitioners or clinicians lean too heavily into the rehab doesn't matter or rehab is training, training is rehab. One, we're afraid to lose clients.
Mm,
We
because the
want to
because
do
because the messaging is that if my rehab doesn't look like this, it's not good rehab. Is that kind of what you mean?
yeah, and it's not going to be fun and
Yeah.
exciting, and it's not like what they're doing. So
Yeah, because the
you know,
internet is saying that if you're not deadlifting in rehab, you need to find a new provider. Where the reality
yeah,
is
yeah,
your provider might be moving you towards a deadlift. And so part of it, I think, is I think the people spreading this message understand that nuance. I really do. But I
yes,
think you hit the nail on the head when you said the way that it's being interpreted by the masses.
yeah,
So
yeah.
sorry, I didn't mean to cut you off, but I feel
No,
like
no,
that was
that's
really
that's
important.
perfect. Yeah,
Yeah.
right. So problem number one is that I think we're getting swept up in the progressive physical therapist
Yeah.
image, the performativeness of having training involved in our rehab plan of care.
Yeah.
Uh, the second one is I think practitioners and clinicians struggle to toe the line productively between more of a gross movement minded approach, training big patterns, getting things strong, and the what we would call what's the opposite of gross, like acute movement minded approach
Yeah.
that is isolating tissues, working on tempo, working on mind muscle connection or motor control. And when you start to skew yourself towards that gross movement minded approach, you tend to lose your clinical mind that you gained in school. I say this because I did. I had to
Hmm.
reel myself way back in and get more granular, if you may. That's the word I was looking for.
And figure out the
That's
nuance, right? Like
mhm.
figure out the nuance. Because what we're not saying training rehab should never look like rehab. We're not saying rehab should never look like training, right?
Yeah.
What we're saying is that you need to understand the nuance of when rehab needs to look like rehab and when rehab needs to start to look like training. There's definitely an inflection point there.
I have one more reason, this middle reason I'll give you an example. There was a time in my coaching clinician career where, let's say, someone came in with a objective strength discrepancy from right to left leg.
Yeah.
After digging deeper, I found that it was most likely due to, or in part due to hip rotator strength, right? Glute med, glute
Inability to
min.
stabilize and produce force.
Sure. At one point, I would have been in the mindset of, I'm going to solve this strength discrepancy problem that's really coming from a stability problem with a gross movement pattern that is lunges or step ups. That's it.
Yeah.
That's it. Right.
The
And to me,
the
this represents
rotation
like
will take
the
care of itself, which I just have
yes,
not
yes, yes,
seen be the
yes,
case.
yes. Right. There might be small cases where the discrepancy is small enough or that person has really good motor control abilities and it cleans up. But I think the more effective scenario is to say like, okay, I do think we need to address the strength discrepancy, and to assist that improvement happening quicker,
Yeah.
more productively, preventing downstream effects. We also need to be doing things like isolated rotational work, like the clamshell. Brought it up purposely
Yeah.
because that clamshell is something we discussed earlier, right? So this is a good representation of something I did, of moving too far into the training realm and thinking that it's going to innocently thinking it's going to like solve the problems. Like, well, this should do it, right?
Yeah.
Problem number three, I think that is causing clinicians to do this is the difficulty around explaining this spectrum, this rehab
Mm,
training spectrum, and explaining to clients why we need to be, having a foot on both sides of the line at the same time. Why I have you squatting right now, but it is a heavily modified squat to keep you out of ranges that are uncontrollable or that hurt, to give you a squat variation that you can control really well. And yes, you are training hard. It's an 80-pound kettlebell. It feels like really good hard work. You have this excitement of wanting to do more,
yeah.
but the accessory on that same day is psoas marches and clamshells, and we are only really training two major patterns at one time. I think clinicians struggle to explain why we're in that scenario, why we're doing both, why it's still needed to be doing the
Yeah.
rehab.
This is very similar to like the you shouldn't rest conversation. Like
Yeah,
and
yeah,
I know that we've talked about this before, but I can't tell you how many times I've had, a high performance athlete come in and just say, look, the entire system needs to cool off. I just want you to take a week off. I promise. Like, we just need this global reset to figure out what the hell the problem is. And again, I think providers are scared to pull that tool out because they're almost being shamed for that, right? And when you talk about this hip rotator, and the lunge and squat, I ran an experiment on myself when I was rehabbing my elbow. I was like, you know what? I'm not going to do any external rotation work, even though it was so weak. I'm going to see what happens when I just do landmine presses because I understand pressing trains the rotator cuff. But guess what? It doesn't train. It doesn't train external rotation. It doesn't target those external rotators. It doesn't give them, in my opinion, the same stimulus and volume. I feel like at that phase, my system needed volume. It did not need load. And so sometimes what can happen is we overshoot because I feel like we're getting all these compensations that are like maybe it got stronger, but it was still weak as hell compared to everything else. And guess what happened? I started doing high volume external rotation. Elbow started to feel better, shoulder started to feel stronger, shoulder started to feel more stable. Like it was a missing piece in training, or excuse me, in rehab. Do I ever do that in training? I don't. I
Mm.
don't ever try to get these high volume scapular, parascapular, rotator cuff stuff going. So it's like we've got to still take Old Faithful and package it in a way that says you have to understand the nuance here. That the goal isn't to just create functionally strong people because we can. The goal is to help people solve the problem while getting them functionally strong. Like, I feel
Yeah,
like you
I agree.
have to take that nuance. And again, this is not a blast to the people that are spreading this message because I think they understand this. But I
Yeah.
feel like there is an interpretation. I have a buddy that is going to a cash-based physical therapist out here, and they they do in-person sessions and then they give away the program. Don't get me started on that. But big opportunity there. But I said, well, let me look at the program. He's dealing with, he's got some labral degeneration in his hip. He's got some osteoarthritic changes in his hip. And I looked at the program and I was kind of like, I think this program is going to get him strong. I don't know that this program is going to have him have a less painful hip. And I think that is kind of a problem because I
Yeah.
think that I believe strongly that there's an opportunity for him to have a pain-free hip because he has the same exact issues on his opposite side with no pain. But my fear is that we're going to focus on the wrong metric.
Yeah, that's exactly it. Stronger is almost always better as long as we appreciate the nuance in that, like, yes, being stronger raises the stress capacity of your system, increases the threshold at which you experience life-changing discomforts. But if you only get stronger, you raise the capacity, and then that space underneath the line is
Yeah.
still filled with annoying dysfunction or discomfort. I find myself, I have been a clinician who says things like, this is the rehab. I remember an example last week. A client at the group fitness gym I'm at has chronic mechanical lower back pain, is afraid of doing hip thrusts. Hip thrusts don't cause a notable increase in pain or increase in pain duration for them.
Hmm.
And I said, we need to do these, right? This is the rehab. Now I know what I mean in that, like, continuing to do the thing, even though it's scary and may cause a little bit of a temporary spike in discomfort, is part of the rehab plan
Yeah.
because we don't want to pull you out and increase that fear and increase the avoidance. We do need to make sure you are getting globally strong while we also do some specific, whatever it is, lower back strength, desensitization, mobility work. Those things need to happen at the same time. I don't want people to think we can't do this stuff until all this stuff is
Right.
solved.
Right.
I think we can do both at the same time if it's deployed in a productive way.
Yeah. I totally agree, man. It's about framing and it's about understanding. Like I keep coming back to this word nuance. And I feel like there needs to be more solo critical thinking about your process
Yeah.
rather than absorbing groupthink of what all the big figureheads are saying
Yeah.
without you actually seeing what's going on in their sessions.
Yeah.
Because you and I agree that rehab as a whole is grossly underdosed in strength training. But
Yeah.
we also agree that there is a time and a place for that underdosing, that there is a time and a place to say, you're really strong, but getting you stronger isn't going to be the thing that moves the needle.
Yeah.
And I feel like not enough people are willing to say that. And so again, this the concept that keeps coming back to me is we are we are strength training our way past the window of opportunity to be pain free. And
Mm,
I'm not saying that that is the truth for everybody, but I think
hmm.
when I'm auditing what is the likelihood that this person could actually come to physical therapy for the thing that they want, I know that like this whole sales concept has been like, you don't want to get out of pain, you want to be able to play with your grandkids. And it's like, but you want to be able to play with your grandkids without pain. Like you
Yeah.
don't just want to be painful playing with your grandkids or painful
Yeah.
playing your sport. Like you want to be able to do that thing without pain. And I feel like we have lost sight of that
Agreed.
a little bit.
Yeah. I agree. I think some of it is losing sight. Some of it is misinterpreting how we go
Yeah.
about it. I think
Yeah.
phase one is yes, you want to get back to the thing with less pain, but we can't forget that phase two is also like, I don't want to have the pain. We
Yeah.
can do both, or both can be true at the same time.
Well, this was really good. This was like us like I think processing some thoughts in real time.
Yeah.
And I'm really interested to see what people have to say about this because again, I feel like it's one of those things where there may not be people that agree with us. Like
Hmm.
I didn't know if you would fully agree with me, but I think what we've uncovered here is discussing the nuance and being like, you know what, that makes sense globally, but it doesn't make sense applying it contextually to this situation. And I
Yeah.
think a lot more people need to pause and need to start forming their own beliefs around these things. And figuring out how you make that your own. I think that was one of my clinical strengths was not just saying, okay, this person said that, that's now what I believe. It's I believe that in this capacity. I believe that in this case.
Hmm.
Anything that you kind of want to send us home with?
No.
Cool. Well, Tyler, thank you for the good discussion. Maybe we'll post this in the community and maybe we'll post it on YouTube as a little teaser for something to come
Yeah.
that we
Yeah.
were
Yeah.
talking about. So awesome, brother. I appreciate you. I appreciate the insight and we'll talk soon.
Same to you, man.